morning. Thank you, Bob. Because of the change, I probably will spend most of my time, or actually all of my time this morning, talking about the staging of lung cancer, because it's the diagnosis part of it is something that is relatively straightforward. The diagnosis of lung cancer depends upon finding malignant cells either in tissue or in fluid, and how you get there can be complicated and convoluted. So I'm going to spend most of my time this morning talking about the staging of lung cancer, and the button is slide button. Hey. Okay. The staging of lung cancer follows the TNM classification that was worked out by the American Joint Commission on Lung Cancer and the UICC. And staging is defined as the assessment of the extent of a tumor in any particular patient. Staging allows for a grouping of patients with comparable disease for prognostic, analytic, and therapeutic purposes. It's in order to make some sense out of the hodgepodge of patients so that you can figure out how best to treat these patients, determine their prognosis. Staging of lung cancer is 4 stages, 1, 2, 3, and 4. This slide depicts the survival curves. You can see that stage 1, stage 2 have reasonably good survival. Stage 3, it drops off. And stage 1, 2, and stage 3A are the patients who are potentially surgically resectable and are potentially curable from this disease. Staging starts with assessment of the T factor. A T1 tumor is a small tumor, less than 3 centimeters in diameter, that is completely surrounded by lung parenchyma. An exception to this is a superficial tumor that does not penetrate beneath the submucosa, can be within the main bronchus, but not involving the carina, and still be classified as a T1 tumor. But for invasive tumors deep to the submucosa, they have to be distal to a lobar bronchus. A T2 tumor is a tumor that is greater than 3 centimeters in diameter, or a tumor of any size that invades the visceral pleura. Proximal extent of the tumor must be at least 2 centimeters distal to the carina. T3 tumor is a tumor with direct extension outside the lung parenchyma into the pleura, the parietal pleura of the chest wall, including the superior sulcus, the diaphragm, the mediastinal pleura, but without invasion deep into the mediastinal structures. T3 tumors are tumors within a main bronchus, within 2 centimeters of the carina, but without involvement of the carina. These tumors are potentially surgically resectable. A T4 descriptor describes a tumor of any size with invasion of the mediastinum, including invasion of the heart, the great vessels, trachea, esophagus, spine, or the presence of malignant pleural effusion. And this is the last slide. This is a T3 pancreas tumor. And this is a T4 pancreas tumor where it has invaded through the chest into the brachial plexus, artery, vein, etc. Recent change to the staging system is that T4 now includes the presence of a separate tumor nodule in the primary lung lobe. Within the same lobe, if there are other nodules of the tumor in that lobe, that is now a T4 tumor. The presence of malignant pleural effusion is by definition a T4 tumor. Patients who have a pleural effusion in association with otherwise potentially resectable lung cancer should have needle thoracentesis, and if the cytology is negative, should undergo thoracoscopy with direct pleural biopsy for complete evaluation of the pleural fluid and pleura. When there's a pleural effusion associated with lung cancer, it is usually a malignant pleural effusion. However, there are the rare incidents where a patient could have a tumor associated with inflammatory process, etc. But in order to operate on that patient, you need to have thoracoscopy and biopsy of the pleura if the cytology on the fluid is negative. Patients that have tumors that abut the pleura and have pain associated with that tumor have T3 tumors unless otherwise proven. This is a CAT scan of a patient showing a tumor that abutted the pleura. The patient had pain, and the patient had a T3 tumor. If the tumor sits against the pleura and the patient has pain, the parietal pleura at least is involved. This is an MRI showing the same sort of thing in a patient with a tumor sitting against the chest wall. MRI and CAT scan are basically equivalent in terms of detecting involvement of the chest wall. If the tumor abuts the spine, it may or may not involve it. MRI may be better than CT scan for involvement of the spine. However, that's controversial. However, if the tumor does invade the spine, as you can see on this slide, there's no question that this is a T4 tumor. Okay. For patients who have tumors in the superior sulcus, MRI is better than CAT scan for detection of penetration through the superior aspect of the chest to involve the brachial plexus, the arteries or veins. This is an MRI of a patient with a left upper lobe pancreas tumor with invasion straight through the thorax, through the apex of the chest to involve the brachial plexus extensively. MRI is better than CAT scan in this situation. May be better in spinal invasion, but that's more controversial. MRI and CT are probably equivalent for chest wall invasion other than here at the apex in the superior sulcus. Definitive evidence of mediastinal invasion of mediastinal structure mediastinal structures classifies a tumor as a T4 tumor, and in most cases precludes complete surgical resection. Both CT and MRI can depict gross mediastinal invasion, but both studies are limited in distinguishing tumor continuity from tumor extension into the mediastinal structures. In the Radiological Diagnostic Oncology Group report in 1991, MRI was statistically significantly more accurate than CT in detecting mediastinal invasion. As tumor abutment, however, does not necessarily mean tumor invasion. Unless there is clear radiological evidence of invasion of the mediastinal structures, the patient should be offered thoracotomy for determination of resectability. And sometimes barium swallow can make the difference, aortography can make the difference, depending upon where the tumor is and what it abuts. But often, you will see we have patients that the tumor sits against the aorta, sits deep in the mediastinum, possibly against the esophagus, and the question of whether the esophagus is involved or the aorta is involved, as opposed to being just abutted by the tumor, is determined in the operating room. And patients, unless there's clear radiological evidence, the patient should not be denied a potential resection. Okay. N1 lymph nodes are those in the ipsilateral hilum or peribronchial region, and they are contained within the visceral envelope or the visceral pleural envelope. These lymph nodes cannot be biopsied at mediastinoscopy. N2 nodes are those lymph nodes that are involved in the ipsilateral mediastinum. These lymph nodes are outside the visceral pleural envelope in the mediastinum, and these lymph nodes should be biopsied at mediastinoscopy. N3 lymph nodes are those in the contralateral hilum, and including those lymph nodes in the scalene region. Contralateral mediastinum, contralateral hilar, or scalene nodes, and N3, patients with N3 nodes, for all intents and purposes, are not surgically resectable. CT and MRI are essentially equal in their ability to detect metastasis within the mediastinal lymph nodes. Lymph nodes that are greater than 1 centimeter diameter should be considered potentially involved. However, no patient should be denied possible curative resection based on a positive CT scan alone. Histological confirmation by mediastinoscopy is required. A normal mediastinum on CT scan with a peripheral T1 or T2 lesion is associated with a false negative rate of 10%. The false negative rate for a CT evaluation of the mediastinum increases to 30% in patients with central lesions. In other words, if you have a peripheral tumor and the CT looks negative in the mediastinum, you're going to be wrong 10% of the time. There will be nodes positive there that you did not predict. If the tumor is central, however, and the CT scan is negative, 30% of the time there will be positive lymph nodes at mediastinoscopy. Okay, mediastinoscopy is safe. It has a mortality rate of about 0.08% and a morbidity of 1.6%. This is probably the biggest series in the literature. There have been a lot of other series, and the results are basically the same. The lymph nodes that can be biopsied at mediastinoscopy are those lymph nodes in the paratracheal gutters here on the right, on the left, and in the subcarinal region. And a mediastinoscopy that is done should include lymph nodes from these three stations: the right paratracheal, tracheobronchial angle area, subcarina, and the left paratracheal. It gets a little bit trickier over here at the left tracheobronchial angle because of the recurrent laryngeal nerve. However, for patients who have tumors on the right side, it is important to, and they have nodal involvement here, it's important to make sure that they do not have contralateral nodes, which will make them M3. Focus on that. Lymph nodes in the aortopulmonary window here. This is mostly This is mostly for patients who have tumors in the left upper lobe. As you know, the mediastinal drainage from the left upper lobe goes to the aortopulmonary window and follows up the ascending aorta in the anterior mediastinum. For patients who have lymph nodes here at level 5 and level 6, they cannot be biopsied. This is not accessible by standard cervical mediastinoscopy. These lymph nodes can be biopsied either by a Chamberlain procedure, which is a resection of the cartilage and direct biopsy, by video-assisted thoracoscopy, or by extended cervical mediastinoscopy that was originally described, I think, in Quebec City and championed by Dr. Ginsberg, where the mediastinoscope, through a cervical mediastinoscopy, the mediastinoscope is passed over the aortic arch down to the aortopulmonary window and the ascending aortic lymph nodes. Those are the three techniques that can be used to biopsy lymph nodes in the aortopulmonary window and anterior mediastinum. PET scanning combined with CAT scan has been shown to be superior to CAT scan alone at correctly predicting nodal status in patients with non-small cell lung cancer. PET scanning can readily demonstrate metastasis to lymph nodes that are less than 1 centimeter in diameter, including scalene lymph nodes. This is a PET scan with a primary tumor in the right upper lobe, which lights up on this scan, and a lymph node in the right paratracheal gutter at level 4. That is, this is, as you know, new technology. It's not available in most of the country, and where PET scan is going to fall out in the assessment of lung cancer, we don't really know. However, PET scan will not supplant CT scan for routine screening with patients, routine evaluation of patients with lung cancer. And certainly patients who have central lesions, CT scan is necessary for spatial orientations, CT scan or MRI necessary for spatial orientations in terms of predicting resectability. So PET scan is for evaluation of metastatic disease, but does not give the spatial orientations that are often required for surgical resection, and therefore CT will not be supplanted by this technology. Okay. Routine scalene lymph node biopsy is not recommended in patients who do not have palpable scalene nodes. Palpable scalene nodes, however, should be biopsied in all patients. Lee and Ginsberg in 1996 showed that if scalene lymph node biopsy is performed in patients with non-squamous histology who have N2 disease, now 30% of these patients will have unsuspected metastasis to their scalene nodes. This increases to 80% for patients who have N3 nodes. Therefore, patients who have non-squamous histology with known N2 disease who are being considered for surgical resection should undergo scaly lymph node biopsy, which can readily be carried out at mediastinoscopy. Assessment of distal metastasis starts with a complete history and physical examination. This is the M factor, specifically looking for performance status, neurological signs or symptoms, and localizing bone pain. CBC, liver function, and calcium levels should be determined in all patients. CAT scan of the chest should include the liver and adrenal glands. Routine bone scan and CAT scan of the brain are felt not to be indicated in patients who have no neurological symptoms in normal liver function studies. The exception to this rule is a potentially operable asymptomatic patient with known mediastinal nodal involvement. Routine multi-organ screening yields a greater number of extrathoracic metastases in these patients, and preoperative multi-organ screening, including CAT scan of the brain and bone scan, is indicated in patients who have N2 disease prior to surgery. PET scanning with the radionuclide fluorodeoxyglucose can detect soft tissue metastases that are not detected by MRI or CAT scan. This is a patient with a lesion in the right upper lobe, and a hilar node, and an adrenal metastasis. And that adrenal metastasis was not detected by CAT scan or MRI. Okay. Patients who have neurological symptoms or patients who have N2 disease, the patient should undergo a CAT scan or an MRI of the brain. CAT scan and MRI of the brain are essentially equivalent for detecting metastases. Only a triple-dose gadolinium contrasted MRI is more sensitive than a contrasted CT. So the absolute, if you have to know, most sensitive test for detecting brain metastasis is a triple-dose gadolinium contrasted MRI. Otherwise, CT is fine, and PET scan is not of any value or not of much value in detecting brain metastasis. Patients with raised alkaline phosphatase or localizing bone pain should undergo a regular bone scan. Regular nuclear bone scan remains the gold standard for detection of bony metastasis, not PET. Okay. This slide shows a patient with a large tumor in the left upper lobe. He's got nodes in the hilum, nodes in the contralateral mediastinum, and a met in his right upper lobe. This is a T3, N3, M1 lesion. Okay, staging. The stage groupings have changed. Stage 1 prior to this included T1 and T2 N0 lesions. Now stage 1 is broken down to stage 1A, which is only those patients with T1 N0 lesions. Stage 1B are those patients with T2 N0 lesions. Stage 2A, stage 2 has been changed to stage 2A and B. Stage 2A are the patients with T1 N1 lesions. Stage 2B are those patients with T2 N1, and now this has been moved up from stage 3A. The patients with T3 N0 lesions who were previously in stage 3A are now into stage 2B. Stage 3 remains divided between stage 3A and 3B. 3A are patients with T3 tumors or N2 lymph nodes. These patients are potentially surgically resectable. Stage 3B are the patients who have N3 or T4 lesions. These patients have localized disease from a radiotherapist point of view. However, they have tumors that are beyond surgical resection. And that is how that's how stage 3A and stage 3B are divided. Okay. Recent change to the staging system again is that synchronous, separate metastatic tumor nodules in the non-primary lobe of the ipsilateral lung are now classified as M1 disease. Okay? The other change that I said before is that nodules within the same lobe is T4. Nodules within the same lung different lobe is M1. Okay. This slide is in your handout. It summarizes the staging groupings that I've just talked about. This is something that you have to know by heart before you get to an examination in thoracic surgery. Okay. Appropriate staging of lung cancer requires both clinical and pathological input. This slide summarizes the survival for potentially surgically resectable disease, stages 1 through 3A. The survival for stage 1 across the board is 67%. For stage 3A, it's 23%. Accurate staging for surgical lung cancer is the responsibility of the surgeon. At the time of thoracotomy, lymph node sampling and resection is required, in the main mediastinal areas to ensure that accurate staging can be determined, that the patient's prognosis and the appropriate therapy can be determined, and that is the reason for staging.